Hi guys, I'm Sarah. Thanks for watching my case presentation. I saw a 41-year-old male in clinic at approximately 10 a.m. one morning who presented with complaints of generalized abdominal pain and associated nausea, vomiting, and diarrhea that had began the night before his clinic visit. He described his abdominal pain as constant and cramping in nature, that he rated as a 9 out of 10 the night before when it started, and a 7 out of 10 at the time of his visit. His pain was followed by 2 episodes of emesis and 5 episodes of diarrhea, last occurring at 3 a.m. the morning of his visit. He reported taking aspirin at approximately 7:30 that morning with little relief to his abdominal cramping, and reported that he was able to tolerate liquids, specifically water and tea, that morning with no occurrences of vomiting or diarrhea afterward. He denied any fevers, chills, decreased energy, weight changes, black, tarry, or clay-colored stools, blood in his urine, stool, emesis, dark urine, dysuria, or other recent illnesses. He was not taking any other medications other than the aspirin he took for the abdominal cramping that morning. Vital signs: blood pressure 127/79, heart rate 65, respiratory rate 20, temperature 98.7 degrees Fahrenheit orally. He was 182 pounds and 68 inches with a BMI of 27.6. His physical exam: he was in no acute distress, he was calm, cooperative, interacted appropriately, ANO ×3 answered all questions appropriately, and was able to move independently on and off the exam table. His abdominal exam: his abdomen was non-distended with no masses or overlying skin changes. Bowel sounds were normoactive and present in all 4 quadrants with no bruit. Soft. His abdomen was soft with mild tenderness to deep palpation in all 4 quadrants, with no rebound tenderness, no guarding or rigidity, splenomegaly, or hepatomegaly. Percussion was not performed. His lung sounds were clear to auscultation, chest rise, symmetric, with S1 and S2 regular rate and rhythm noted on heart and lung exam. His skin was warm and well perfused, with a normal skin tone for his race. The diagnoses I chose: the leading diagnosis being viral gastroenteritis, because his pain was cramping in nature and a new acute onset. Acute gastritis with H. pylori infection was my second diagnosis. However, this patient's pain was not associated with eating and was not localized to the epigastric area. Third diagnosis I chose was hepatitis A infection. However, this patient did not present with dark urine, jaundiced, or with clay-colored bowel movements or fever. I chose to review the American College of Gastroenterology's clinical practice guideline on the diagnosis, treatment, and prevention of acute diarrheal infections in adults, which is a level 4 of evidence. This gives some public health considerations are mentioned in the guideline on the importance of reporting any outbreaks and culturing stool specimens in the case of an outbreak in order to prevent a public health crisis. But then it focuses on the treatment, prevention, and prophylaxis of acute diarrheal infections, and also talks about traveler's diarrhea, so mentions patients traveling outside of the U.S. as well as acute infections within the U.S. This article is definitely, and its recommendations, the guideline is definitely generalizable and of use in my future practice. The CDC has estimated there are approximately 47.8 million cases of acute diarrheal infection per year in the United States, with an estimated cost to the country of about $150 million per year. Take-home points from this guideline: the first one being antibiotics are not recommended for acute diarrhea infections as treatment in adults unless it's traveler's diarrhea, because the cause is usually viral and antibiotics do not shorten the duration of illness. Second take-home point, supportive therapy is recommended as treatment to support symptoms. So oral hydration with broths, juices, and carbohydrates. However, in the elderly and infants, it is recommended to use oral rehydration salts that can be purchased over the counter, because these populations are at higher risk for complications and dehydration from associated diarrheal infections. The last take-home point is that the use of probiotics and prebiotics for acute diarrhea in adults is not recommended, except in antibiotic-associated diarrheal infections. There is apparently not sufficient evidence for the use of probiotics or prebiotics. The guideline mentions some safety concerns, but doesn't state what they are. The care given in clinic last week to the specific patient matches these guidelines because antibiotics were not prescribed, and probiotics or prebiotics were also not prescribed. The patient was educated on supportive care and advised to seek treatment if his symptoms lasted 7 days or longer and did not resolve. Future tidbits to hold on to for future practice. Since this guideline talks about traveler's diarrhea, this information is also useful when seeing patients who will be traveling abroad. It talks about the use of bismuth subsalicylates, like Pepto-Bismol, are shown to be effective in the prevention of traveler's diarrhea, but must be taken 4 times a day, every day while abroad. Interprofessional care of this patient was not necessarily given. A medical assistant assisted in taking vital signs and relaying initial intake information to myself and my preceptor as the providers. However, no other interprofessional care was warranted in this situation. Thank you for watching.